I'm going to ask a few questions just to start the conversation going, but I'm hoping to reserve most of the time to take questions from the audience. The first, just to dive down on the evidence question a little bit, is as Kirk mentioned going through the data, you have seen some changes over the years. The mortality figures, specifically, if you look at the 1990 report, the 2000 report, the WHO estimates that have come out in between and now really are quite different. 90 report, I believe, is a bit over 4 million. The 2000 report, I think, dropped down to 1.6, if I'm remembering that correctly. The WHO estimate that came out in between this report put it at 2, and now we're back up to 3.5. The question I have on that is, what is a policymaker to do with that type of data in this case? Is there enough here for policymakers to start reassessing priorities? And if not, what would you specifically like to see in the short term to try to address that, policy confusion that exists around the data?
Well, a couple of questions there, but I said, the official line, you will see it in every one of the papers in the Lancet, is drop the 2001, it's not relevant anymore. But I realize that's going to be hard because everybody's been using those numbers for a long time. And so that's why in that little summary that they put on the website, I go into some detail why there is a difference. The big differences are we have better data. We're able to estimate impacts that we weren't able to estimate before. I mean, you know, when you do one of these exercises, it's a very interesting thing. It's a comparative risk assessment. So that means, you know, if we Kapan and I publish a little risk assessment about household air pollution, and we do the best we can, and we submit it to an air pollution journal, and we deal with reviewers from the air pollution world, that's one thing. But that's not a C. It doesn't have a CRA. It's just an RA. The CRA is we have to go up against the blood pressure people, the tobacco people. You know, people with huge databases, and and millions, billions of dollars in the case of tobacco spent. They understand exactly, you know, from our standpoint, what they're doing. So we have to be very careful. We have to put up what we really know. And back in about 2002, when we were doing the previous one, we could only make that estimate for COPD, pneumonia in children, and lung cancer, but only lung cancer from coal smoke. Well, now we have a lot better data. We have lung cancer from biomass, too. We have ischemic heart disease. We have cataracts. We had enough data now to put those up, to be willing to go against the blood pressure people with those numbers. Meanwhile, the blood pressure people, too, had new evidence, and they readjusted some of their old evidence. Our COPD risks are actually lower per woman than in the past because we have better data. Secondly, we took this very low counterfactual. We said let's say, what if those 40% of the world that use these dirty fuels could have as clean an environment as you and I have? So we've taken down to 7, but let's just think of it. What happens if we take those 40% and give them all gas cooking and electrical cooking devices? Now you'd say, well, that's economically infeasible. But it's not infeasible technically. I mean, 60% of us are doing it already. I mean, it's not a big deal. It's hardly, rocket science, really. So we figured that was justifiable. So that gives us a lot more burden as well. So it's not directly comparable with the 2000 numbers. I mean, the 2000 was a different world. Now let me say something else that I should have said. We also have a number of other diseases that we did not put up. We did not feel comfortable putting up. This time against the blood pressure. I use blood pressure because they have such great data everywhere. TB, we have a number of studies showing that household air pollution is a risk factor for TB. In fact, several studies have been published in the last couple of years. We probably would put it up if we were doing it today. Low birth weight. We have some evidence on low birth weight, but that wasn't put up either. Cognitive effects. We have 2 studies on, basically IQ in children who are exposed to this. Cervical cancer, pneumonia in adults. The next time, if this is done again in 5-7 years, those things are going to be across the line too. But they didn't meet the criterion of satisfying the evidence. So, I understand this is hard, but that's why it was done for 1990. You can take the 1990 and the 2010. You can draw lines through it if you like. get yourself a trend. But the 2001 is just historical evidence at this point. I'm sorry, I don't know what, you can tell me how to frame this. I'm trying to learn how to frame it too. I mean, we're just learning this, but let me make a prediction. The worst thing you can do is put burning stuff in your mouth. And we have a huge amount of evidence of what happens to you when you do that. Almost every cancer you can think of, almost every, adverse type of pregnancy, birth defects, infectious diseases, you name it. Well, we don't have that much evidence yet on household air pollution, but it's the same kind of risk. We're finding the same diseases that we found with smoking we're busy finding. In 10 years, we're going to have another 10 diseases of the type that we find for smoking, also for household air pollution, at lower risk levels, obviously. It's not as bad as sticking it in your mouth. But it's the same set of things. So as science progresses, we push new diseases over the threshold, and those new diseases then link us to the burden of disease for those diseases. And the big one this time was heart disease.
Great. Let me ask that question to Lynn as a former policymaker at EPA. What would this data mean to you? WHO hasn't endorsed it yet. It has moved around significantly over the last couple of reports. What does a policymaker do with this data? What more needs to be done in the short term to put it in a form that policymakers can act on it?
So think about it from the perspective, again, of what just happened today in the United States with EPA lowering the PM 2.5 standard. Why did that happen? It happened because in U.S. law, every few years, EPA has to reevaluate certain air pollution standards, including the standard for PM. And this time around, there was science that didn't exist 6 years ago that supported a lowering of the standard. And that's the reality. And I think that there's a lot of truth in what Kirk Smith said in terms of the fact that, we can only make conclusions with the science we have at any one point in time. And what we have today is a lot more than what we had 10 years ago. We expect we'll have more in another 10 years. The problem always is that policymakers have an irritating way of learning numbers and latching onto them and really clinging to them, that it's this number million for this and that million for that. I've never suffered from that because I forget numbers. But it's why I do think that it's important to look at trends. I think that more important than the absolute number is the direction where things are going, and also where we can take things by taking action. So although in 10 years probably the numbers will be different numbers, there will be new things that we will have learned, and usually that does go in a direction of things like air pollution being more hazardous, because the more we learn, the worse things are. But also, as we lower the levels that people are breathing, we're able to see what's going on at lower levels. When we looked at PM in the United States 30 years ago, we couldn't have seen the things that we can see today because everybody was breathing much higher levels. And so it takes a leap of faith in a way to understand, and maybe there needs to be an education of policymakers about this, as has happened with air pollution in the United States, that it's just important to go back periodically and reassess these things. Not to stop these assessment processes, because you never reach that point where you know everything, but to do it periodically, go back and be willing to do it, and focus more on the good that can be done through action.
Kalpana Stumi, your take on this, working on this issue closer to the ground on the country level, or through a non-governmental organization trying to address, or public-private partnership rather, trying to address these issues. Is there enough data here? How do you deal with the fact that there is this divide with WHO and the data has moved around a little bit? Is there enough to be actionable here? What does this data do for you? Is there something specifically you'd like to see in the short term to develop it in a way that would help with either your advocacy or the interventions that you're doing? Bossman.
I think one thing that we've kind of spoken around in terms of the progress, but that we haven't really addressed directly, is the fact that these types of comparative risk assessment exercises also kind of identify very clearly where the new direction in research has to go in terms of where the evidence needs to be strengthened. And I think that that's actually quite valuable. I was just thinking back, the first round of estimates that were done, at that time, for example, there were only 53 household surveys that we could use on the exposure side to do our model, and now we have well over 600. Similarly, a lot more emphasis, I think, on other health outcomes, and we actually also know the places where we have, strong and compelling evidence, but where we were just not strong enough to be included. So those are the areas where we can say, okay, these are the places where we need to really focus our efforts before the next round. So I think that can be very, very helpful.
Great.
Yeah, I think the biggest addition to the data set, as much as, in my first part I talked about the challenges of using an integrated exposure response, but as the scientific community, it affords us a fantastic opportunity to talk about near-term interventions that might get you down on the exposure response curve. And the counterfactual that Kirk was talking about in the previous assessment was not using solid fuels. So not using solid fuels is not 7 micrograms, not using solid fuels in some of the communities where the solid fuels is being used is 60 micrograms. So then that's where the gains, much of the gains in terms of the increased burdens have happened, is because we have lowered our counterfactual to 7, but then we might also be able to do an in-country calculation on where might 20 get you, where might 50 get you, and if you, and that's a message that I think quite a bit of the efforts that are going on in terms of cleaner cookstove technologies should be happening, that we package this message together. You need to do this, and that's the goal, but if you can't boil water and chlorinate and buy bottled water, there are these intermediate steps that would all get you there, is a lesson that we can learn from the water and sanitation. I mean, at no cost, saying that doing anything that is not going to be completely protective is something that we recommend, but at least make sure that if this is what you get, this is the benefit. So I think that we do have the data right now, in fact, better data than we ever had before for action. We just need to get creative in terms of packaging this in a policy message.
Great, that's a great answer. And with that hopeful answer, let me turn it over to the audience. If you raise your hand, I will call on you in the order in which I see you. If you could just state your name and your affiliation. There's a microphone that will go around the room. Sir.
Hi, is this working? Okay, I'm John Brazeau. I head up the Maternal and Child Health Division at USAID. And so for us, how to use this information for policy making is not so much about regulatory issues as much about resource allocation and thinking about what we should prioritize. I want to say that it's incredible that you're able to do this kind of work. I mean, I really appreciate the complexity of what went into this, and I think the discussion and some of the things that you've been talking about that relate to the nuances of how to interpret this have already been quite valuable. It's nevertheless still a challenge to ultimately interpret this, and I think that what came out on Friday is going to require a fair bit of unpacking and analysis to understand how potentially to use this. And within maternal and child health, there are a lot of things, a lot of areas that require attention and investment. Immunization for kids, undernutrition, glad that emerges. Relative merits of investing in water and sanitation interventions versus the issue of household air pollution. And so I guess one of the challenges in terms of understanding this and unpacking it is really to think more about this issue of the counterfactual, because this has done a really good job at laying out, in my opinion, the extent of the problem. But to do the kinds of things that are actionable in terms of prioritizing resource allocation for taking action, it really requires that you understand what you can actually achieve by concrete investments in known solutions. So, for example, I think as Kapalna was saying, the real issue of looking at a practical country level, what can you really achieve, and then what will be the implication of what's achievable is an important question. I think that, for example, one of the questions I'm asking for the Alliance is if you really believe that to achieve these kinds of impacts, you have to achieve a level of 7, what does that mean for emphasizing improved stoves versus a switch to cleaner fuels? These are some of the questions that I think that this research is really engendering. And then I think the other piece that's critical is something that's already been said, which is this is just a step on the way to increasing in our understanding. And so, I would not advocate that, for example, I have no idea if we look agency-wide within USAID, it's probably in terms of our health spending, it's probably 30-to-1 in favor of water and sanitation versus household air pollution. You turn that upside down, I wouldn't advocate you do that. But you use this to say that you look at the trend, I think, as Lynn was saying, and saying this is something we have to, over some time, pay more attention to, and it's really valuable that way. This issue of looking at potential solutions at the policy level, I think that's the things we want to look at. For example, I think that in India they've done this thing in Maharashtra State, which is no toilet, no bride, or something like that. These kinds of creative ways of providing new incentives are things we have to look at. The programmatic side of this is particularly important. And then a couple of questions. One is, this issue of nutrition is so overarching. And as you said, Kirk, in your opening, that for the comparative risk assessment analysis, it's not coherent. And so nutrition can enter into this as water and sanitation is a risk factor for nutrition. As Lynn was saying, there's indirect ways in which household air pollution is a risk factor for nutrition. So I'm not fully, I think this is one of the things I have to unpack for myself, is how do all these different things tie together into things that are in fact very high level. But again, it's really a lot of food for thought. I hope that we continue to have these kinds of discussions to try to unpack this and further understand its implications. So thank you.
Great. What a rich question I heard there. Do we have enough to know what you can achieve and where you can achieve it? How does it change our conception of what the interventions need to be? Do we have enough to start shifting resource allocation? I don't know. It looks like Kirk would like to go first.
Well, let me just take one piece of that. Not mentioned, but implied by what John said, is that water and sanitation came out extremely low in this new exercise. You notice it wasn't even in the top 20 risk factors in the world, which is rather astonishing, I think, to most of us, and of course inverse to a lot of funding priorities currently, in the way we think about diarrheal disease is so important for children in developing countries. And if you have a technical interest in that, there's actually quite a bit of text in the article that explains that, because they knew they were going to get they were already getting a lot of pushback on this from WHO and others even in the drafting stage. So I think they've done a good job with the science, but undoubtedly there are arguments otherwise. But one of the reasons is that we've, in a sense, leapfrogged past, we in the household air pollution business have leapfrogged past the water and sanitation people because of our link with outdoor air pollution and secondhand fuel and smoking. You don't have these kind of ways of framing the entire structure of the risk period. You also, in water and sanitation, there's no exposure metric. You can't measure, like micrograms per cubic meter or something like that. So you're comparing one type of water use with another, or one type of sanitation with another. And reevaluation of that literature, and and I'm not an expert, but I have queried close colleagues who are experts, Jack. Nothing works. This is the problem. I mean, in terms of when you actually do the EPI, those interventions aren't working. You give people clean water, it doesn't make that big a difference. You give people latrines, it doesn't make that much difference. And so, they don't have an exposure metric to go all the way down to their equivalent of 7. So they have to rely on, comparisons across, existing interventions, which don't work very well. I mean, I would say they don't work at all, but they don't work very well. So that's a very big reason why the counterfactual is, what is it? So, and now, that's very sobering, I must say, for us in household air pollution, because a lot of people have spent a lot of time worrying about water and sanitation. A lot more money has been spent. I mean, I like to say that when did the causality of human waste in the water being bad for you, when was that established? Well, you'd think we could have learned that 10,000 years ago, but we didn't learn it until about 1890, when everybody started taking sewage systems, seriously and so forth. So at 120 years, there's been no question about causality in terms of human waste in the water. And yet we still don't know how to fix it in these poor populations. It's that poor populations is an important caveat. And it's because of the same kind of reasons that we have. People are poor, there's no money to be made by providing them anything. So there's not a big effort on the, in the engine of private enterprise. And the behavioral changes required. There's an easily available, free alternative defecating in the field or getting a bunch of sticks to make a fire. So it requires behavioral change. So one of the, what I'm a little worried about is now that we're maybe just crossing the boundary of people accepting causality, except a few physicians in India, or many physicians in India. That doesn't mean, just knowing that something is a risk factor doesn't mean you know how to fix it. And unfortunately, in the water and sanitation field, I'm talking about poor population. We know how to fix it. We have flush toilets and treated water. That works. But assuming that isn't going to be possible in these populations soon, it's not so easy. Now, I think if we had a exposure-response relationship with water and sanitation, it would allow us to do the 7 equivalent. Then you would see a bigger potential benefit. So it's suffering. I mean, it's odd, but we were able to, because of our link with the large air pollution community, able to go down to 7. We wouldn't have been able to on our own. Yeah, so this is, maybe a little bit. That isn't discussed in the Lancet article, because they don't compare it with household air pollution. They just try to do it with. But basically, they say that reevaluation of those studies show that there are no obvious interventions that really get you improvement, that are usable in these populations. So this is, and that's something for you and your colleagues to think about, serious thing to think about. Now, there are other kinds of outcomes. I mean, my colleague who works on this area, he says they're focusing on child growth outcomes. It's not diarrhea anymore. It's subclinical infections that change the entire flora and fauna of the gut. The child doesn't grow. It ends up with cognitive impacts, long-term chronic, from subclinical diarrhea, if you will, or infections. So that, maybe diarrhea isn't the right metric here. I mean, we all think of a bad thing to have, fecal matter in the water. But maybe diarrhea isn't the best metric for it. But there was no child growth outcome in the GBD. On the other hand, we probably have, in the household air pollution, we probably have some impacts there too. So if you add child growth, maybe, we'll get a better picture on all of this. Sorry, I just wanted to take the teaching moment for the
Great.
technical point.
On interventions for household air pollution specifically, how does this data help inform the discussion of what can be achieved, where it can be achieved? Does it change the interventions we should be focusing on?
Well, I think that it's really increasingly a big focus as we think about scaling up interventions and really thinking about as well the standards development process in terms of how we actually define clean, so that we can really think about not just clean for the environment in terms of decreased, increased efficiency, but also really thinking about clean enough for health and really getting down to those lower levels where we are more confident that we'll be observing health benefits across the range of health outcomes that we have to look at. So this is something that we are really, trying to carefully integrate with the standards development process, both through ISO, but also through the indoor air quality guidelines of WHO as well. So.
Just to comment on the point that John made, I think that water and sanitation interventions, because they've been supported for a long time, then we've learned over time that some of them don't work over time. They work at the beginning, and then communities are not able to sustain them. They're not able to maintain them. And communities grow, they outgrow them, or they don't invest in the infrastructure, keeping the infrastructure going, or they break down because of energy requirements and other reasons. And I think there are lessons to be learned from that in this world of working on household air pollution, that it's not just a matter of, are you getting your bang for your buck in the immediate time period, but over time, the sustainability of the interventions, the ability of communities to be able to maintain progress. And I think that's extremely important and needs to be attended to. And I guess the other response I'd have to that is that these are global data that allow you to see trends on very broad scale. But in individual countries and in individual communities, the best investments might be completely different than either sanitation or stoves. It could be in certain communities that that malaria is by far and large the most important problem. And so I think it's very, very important that funders have flexibility about going in and and really looking at the public health systems and communities, taking an approach that is open to the most important problems that exist in specific places where people live.
In terms of resource allocation, I don't know if this is a strategy that can work, but identify opportunity of piggybacking existing governmental positions. I'll give you an example in India of the Ministry of New and Renewable Energy wanting to already endorse LPG equivalent technologies or a cookstove technology that matches the conditions provided by LPG. So this is our perfect moment to endorse that, saying that it's not just because LPG is cleaner and provides quality of life and a source of energy in non-health terms, but here is a way to endorse that. So I think that's one way of efficiently piggybacking onto a resource that is planning to be allocated anyway, at least in some measure. The second measure, if I may wrap this up, is what Lynn suggested is in local communities, if you need to do something about it, the need to strengthen public health systems with better disease surveillance systems. I think that's one way of, again, efficiently increasing the resource allocation is there are plans to do that in different parts of the world, and this is our opportunity to say, so look, this is what you can actually do, and this is the need that will, that without that particular disease, local disease surveillance system or local public health data collection systems, there's no way that any of this information is usable for local policy.
Great. Eric.
John, you'd be interested in this. John's not listening. But, there are a lot of analogies between the household water and sanitation and the household air pollution business. I mean, it's water, it's water and sanitation, it's clean fuels and ventilation, and a lot of behavioral aspects to both, both in the very poorest populations. But one of the things that's come out of our recent work, it's not just in the comparative risk assessment of our own research, is this whole idea of household air pollution, that it's contaminating the whole environment. Some people cook outside. Well, you intervene with a very clean stove, the cleanest you want. But if she's cooking outside and there are 3 other women nearby cooking with her old stove, what happens to her exposure? It doesn't go down that much. So maybe you need to think of community level or compound. If you've got 5 women living in a compound, which happens in many places, Africa, for example, you can't just intervene with one. Well, the household sanitation, but you put in one latrine, and all the other houses nearby are not using latrines. I mean, how much benefit does that house get? Because the problem is the waste getting into the water supply. So you have to give everybody latrines. Well, in a compound, you've got dogs, defecating, and turkeys, and been in these places, all sorts of things, and people holding their babies out over the ground, and so intervention at the household level, which we have focused on a lot in the household, in the air pollution business, but so have the water and sanitation people. It's this community environment, the hygiene, the hygiene taken broadly, that is common to both, actually. And of course, this has profound implications for how you would promote, say, an advanced stove. Now, if a household, we're doing a study, Kalpan and I, a study in India, where we're introducing it through the prenatal care system, introducing for one pregnant woman at a time, has many advantages. But obviously, a pregnant woman, not everybody gets pregnant at the same time, so you're intervening, one household at a time. Over time, you get a lot of households, but in the meantime, the household air pollution is around from the other devices. So maybe we have to think about, in the water and sanitation, I know they are, thinking about intervening in whole villages at once, or whole compounds, or fractions of villages, in order to really bring the their equivalent of the PM down, the fecal matter and that people get touch down to lower levels. So. I think the science is sort of, causing us to think a little bit about, how we think about intervention, in addition to the gadgets themselves. But what is the best way to make this happen?
Great. Other questions from the audience, sir?
My name is Bill Scrivens. My name is Bill Scrivens with T3 with Haiti. And one thing I haven't heard spoken about is trash, taking care of trash and outdoor air pollution. And what I find is that in Haiti, particularly in the urban areas, they're doing slow burning, smoldering fires to take care of their plastics, all the trash that they have nothing else to do with and can't get rid of in any organized way. And has that been brought into thought of how this outdoor air pollution fits into this overall scheme?
Well, I can just say that you can't control outdoor air pollution if you've got open trash burning. I mean, you've got to fix that first. That's what every city, that's what Los Angeles had to do in the 50s. There isn't any way to deal with outdoor air pollution if you've got smoldering trash. So you have to collect it and deal with it. So garbage collection is part of outdoor air pollution control. I mean, that's the simple answer. So you've got to collect it. Do something else with it. Yes. Well, no, the governments know how to collect trash. It's not a big deal. Most governments in the world do. It's government's failure if they don't.
You can also generate less of it, which is another, but anyway, yeah.
And it does, I mean, if you look into more detail about how the ambient air pollution estimates have been made, I mean, they do take the concentrations into account, and so in some places it is quite a major source of the pollution that's integrated there.
Great. More questions? Sir? Okay.
Hi, so I guess I'll stand up. My name is Luke Bossman with the GACC Foundation. And I guess my question is about, we talked a little bit about kind of what interventions could be done, but I guess I'm kind of curious to hear, I mean, you know, it looks like from one of the graphs that Kirk showed earlier, that the incidence has gone down in some places, the rate has gone down, and some places the rate has gone down even while the kind of overall burden is going up because populations are just increasing. And I guess I'm wondering, it was also interesting to note how closely it tracks with poverty. And so I guess I'm wondering, in addition to just simple economic growth, which seems to have all kinds of great effects on health and everything else, what things have worked as far as reducing rate in places where the rate has been reduced over the last 10 or 20 years? Are there kind of any clear success stories, or can anything really be attributed or not?
Well, okay, the trends are a function of several things. One is the number of people exposed. Well, that hasn't changed much. The level of exposure hasn't changed much, and there aren't that many, unfortunately, so-called improved stove programs around. People are almost everywhere burning open fuels. But there are demographic shifts. There are fewer children. You know, fraction of children is going down in the world. So I mean, you can't die of pneumonia if you're not, child pneumonia if you're not a child. Secondly, unfortunately, public health has improved around the world. There's less pneumonia than there used to be. There's actually less COPD than there used to be. So these are, the way these risks are done, it's an exacerbation of a background disease, or the background disease has gone down. So we went from, in the old, if you take the 2000 version, it was 1 million child deaths. It's 500,000 now. 500,000 is more than 1,000 a day. It's not something to ignore, but it's not 1 million. But that's largely because there's less pneumonia now. And that's due to other things. That's due to better nutrition, vaccines that are out there, better child, primary health care, and so forth. Not because of a change in the risks from household air pollution. Now, no, I mean, the answer to your, other question is no, there aren't very many examples of, except the example of people moving to gas. Hundreds of millions of people have, well, let's put it this way, hundreds of millions more children are born into gas households than they used to be. So that's the intervention. Now, so some people, you're implying something that I get sometimes in public audiences. They say, well, Dr. Smith, isn't this just a problem of poverty, and we just fix poverty and we fix this? Well, yes, it is a problem of poverty, one-to-one. I can guarantee you that none of the 2 billion poorest people in the world are using gas, and just as none of the 4 billion richest people in the world, including us, are using open fires in our kitchens. It is a one-to-one with poverty, but that doesn't mean that poverty reduction is a very efficient way of getting at it. And it's a very inefficient way of getting at it. If you're happy waiting till everybody's rich, yes, they'll probably all be using gas then. But that's a long time, and it's 2.8 billion people that aren't moving off the dime. And so if you want to help those people, you've got to do something specifically for them. Obviously, poverty alleviation is an important part. Now, one thing that we don't talk about much related to this is electrification. About half those people that are using solid fuels don't have electricity, but the other half do. And electrical appliances are a great way to reduce household air pollution. I mean, you use a rice cooker, an electric water pot, all these things. Every time you don't light a fire to cook something means less pollution. So electrical appliances, all your houses, I had a student come up, we had 19 different cooking devices in my house. 5 different coffee makers and a popcorn maker and a waffle maker and so forth. We still had a stove, but a lot of meals went entirely by the electrical devices. And so electrification is part of the picture. It provides lighting so that you can get away from kerosene lamps, which are really nasty themselves. We haven't talked about kerosene. And it allows you to pick off the major cooking tasks. Everybody who cooks rice should have a rice cooker. It's efficient, quick, clean, doesn't use any fuel directly. Even counting the electrical losses in the power lines, it's more efficient. So, that's why Radha talks about, where's Radha? She talks about cooking solutions. It's not just the stove's part of it, but is recognizing that cooking as a set of tasks and picking off the most efficient and cleanest way to do each of those tasks. And that includes electricity, includes gas, includes clean biomass stoves.
Great. Anyone else on what works and whether or not this report provides any additional data on identifying that?
I also think there are creative ways of targeting people for whom it's not a resource issue in terms of if they had preferential allocations that they wanted to be spending the money on, and probably mobile technology is the single biggest example in India, something that's quoted often. The 700 million who don't have cleaner cookstoves do have a mobile phone. And 3,000 rupees is what it costs to buy a mobile as it costs. I don't quite know how the analogy can be stretched, but what we're looking at is target people for whom even if they are poor, if they have some minimum spending capacity, how to guide that spending and what might be beneficial for them. And if this can be packaged into household spending preference change, then there's an opportunity for resources that can be addressed.
Great.
And if I may, I think that's why the local information is so important, right. Just to get back to that point. And that is that those people are more likely to make that decision if they understand that it directly would benefit the health of their own children and the children in their community and their own health. And they don't know that. Right. And I think that it's a terrible shortcoming and just the lack of good health data in most of the communities in the world. Right.
And if I may also respond, I think John was mentioning during the conversation that sometimes we get very shy about evidence that is less than perfect as scientists, and we do so in the interest of being defensive and protecting our own scientific integrity. And I think some of us have to sort of really, we know the evidence is imperfect, but to not sort of really take cover under our own sense of professionalism to not pass on this message. So that is again another strategy that hasn't been used so much. And when we start sort of looking at all the uncertainties around the numbers and all the difficulties in interpreting the evidence, we don't end up selling good things hard enough.
Great. Gentleman over here, and then the gentleman over there.
Yeah, so 2 questions. I'm Jacob Moss. I'm with the U.S. government. I coordinate our Cookstoves efforts. First is, it seems to be embedded in a lot of the graphs, but is there a plan to release sort of, and this gets to Lynn's point, sort of country by country data of kids dying, adults dying, men versus women, by what disease, and that could go a long way to helping with some of the points she's making. And is that available now? Will it be available? What's the story there? And then secondly, from a U.S. perspective on the policy side, we've made this tremendous investment of, we say up to $114 million. That's $50 million, up to $50 million in financing, about $60 million in applied research on health effects, on technology, on adoption, on stove testing, on other pieces. Does this report should it change that? Are there gaps in that we're not getting at? Are there pieces that we should be overemphasizing or emphasizing more now, or de-emphasizing? Should we just be doubling it? Is that the answer? What's the we don't have what we don't have is a pot of money to then go assign. What we do is we work with different agencies and they make investments on their own, given what they do, using the processes they do. But would you have a recommendation? Would each of you have any given recommendations for how we're investing on the U.S. government side, given the data and the story that comes out of this report?
Great. First, anyone willing to take on the question of data access? Do we know what the...
Yeah, I can answer that. The answer is yes, but I don't know when. I mean, that's under control of the Institute for Health Metrics, and they have a lot of stuff on their plate at the moment. A few months, I would guess. They'll be on their websites. Check their website.
The one thing I will say, they did announce on Friday that they will be, over the next 12 months to 18 months, doing using that data to make future projections, something that had been done in previous iterations of the report, but not this report. So one wonders if that might be a link to one of the data.
They already have some, but they're going to put in more web-based tools, so you can do your own manipulations, on using their software and get some interesting results. But certainly that will be available at the regional levels. Now, the country-level data, it's a little bit more politically difficult. None of those regions is just one country, because the idea is not to, some of them are only two countries, like U.S. and Canada, but they're together. So
WHO published previously the national burden.
Yeah, I know. So I don't know, but that was WHO. So I don't know what's going to happen. Perhaps they don't know either. They are going to publish life expectancies and those kinds of data at the national level. Whether they publish the CRA results, first of all, won't be their highest priority. So I think it'll probably eventually be available, but not soon.
Great question. On the so what question vis-a-vis cook stoves, what does this do specifically on that intervention? Any change on what should be done in that area? Or U.S. investments in general, I should say, in that area.
One thing that one might consider, specifically since this was a health-focused outcome, you just wonder, I think a lot of the U.S. government support on the health side of this, of course, has been through investigator-initiated research, and one wonders whether this might kind of cause NIH and others to have more motivation to have maybe some more specific targeted calls for research related to this issue.
I'm one of the things that strikes me as being the need for developing countries. I don't know the answer of if that's the role of U.S. government to actually fill this need, but I know that the strengthening of public health systems, and I'm again coming back to this, there's already efforts going on for many other risk factors, but I think environment and disease surveillance haven't sort of been put together. So I think that the water and sanitation people would be greatly benefited by it. The air pollution people would be greatly benefited by it. So anything that looks at in-country capacity strengthening to get better environmental health data, environmental indicator data linked into the ongoing in-country efforts is certainly, without which, there are many, there's a long list of, on the wish list, but I think without this fundamental data locally, once the data is there, they can see it for themselves, and the convincing process becomes much easier. So this is just a suggestion out of the many things that are possible.
Great. Please.
So I've been thinking about your question and how several years back the global AIDS epidemic then eventually inspired not only the PEPFAR, but a tremendous amount of new resources coming into the area in order to deal with not only the AIDS, HIV epidemic, but also the conditions that are causing it. And I think these global environmental issues, and I think it's both the issue of the household air pollutants, but also the problems with water in communities, that there hasn't been that level of commitment, of focus, of collaboration across the government, between the government and not-for-profits and others who could be inspired to really bring in new resources. I mean, given the fiscal situation, I can't tell you double your budget because I know you can't do that. Of course, if you could, I would be saying that. But of course, you have to stay the course. But I really hope that this report will help to call more attention to chronic disease and to environmental issues related to chronic disease in particular. And I think this has been very much neglected.
Great.
Can I respond to the question? I mean, there's a, sort of the cynical answer. I have a close colleague, a giant in the field of air pollution, John Samet, we all know. He has one slide he always starts every lecture with, more research needed. That's his bottom line. So it's easy for us researchers to say that. And we've mentioned some things, heart disease, for example. But let me tell you a story. When we had our the first randomized trial published a year ago or so in Lancet and called the media relations office on campus, they like to know about a big article coming out, of course, and make a big deal out of it. And the woman there said, "Oh, wonderful, what's it about?" And I said, "Well, it's about air pollution and child pneumonia." And there was this kind of silence. She said, "Well, of course air pollution causes child pneumonia. What's the big deal?" And I was sort of taken aback, and I said, well, we have another study coming out, just happened to be coming out the same week, which was on cognitive effects in children. And this was not a randomized trial. It cost $5,000 instead of $5 million. It was 39 kids instead of 500 kids followed for years. But it showed a very strong effect that those mothers who had higher exposures during pregnancy, we'd measured them, and 6 years later, their kids had lower cognitive performance of cognitive tests, not IQ, because we didn't have a validated IQ test in that population, but it was pretty convincing, at least for this small data set. She said, "Oh, that's a story." So, sometimes I wonder, and there's the lead story. We knew about the health effects of lead. Lead causes almost, a terrible bunch of things also. But it was when they started really pinning down the effects on child IQ, or whatever you want to call it, in the late 80s and 90s, that every country in the world got rid of lead out of gasoline. So maybe, maybe there are, special, I don't know what we call them, charismatic or things that really catch people's attention. And cancer tends to be that way. Cognitive, children's effects in general, but pneumonia somehow doesn't seem to do it actually. But maybe cognitive effects, or we have a study going now on child leukemia. So this is it's a sort of strategic epidemiology. I justify it ethically myself, and I'm pretty well convinced that there's some really big effects here. But then, how do we get policy moving? Well, you respond to what people will listen to, get good evidence for that. And I wondered, actually, after talking to this woman, if instead of, it took us about 20 years or more to do this get the money and do this randomized trial, we'd done 5 studies on cognitive effects, whether we might be further along, because every, parent in the world is, has something special about cognitive effects. So that's another thing, since we're talking about health, whether to beat another nail into the coffin, the pneumonia coffin, or should we, bring out some more coffins and see if we can get the nails in those.
Great. I know we have a number of questions, I think 3 all on this side of the room. I will say while I give Sean a chance to walk over, one of the big conclusions of this report, of course, was young adults really are going to be seen, I think, for the future as one of the neglected focuses of global health, and the numbers there are really were quite surprising. It's one of the headline features of that. Why don't we the gentleman back in the middle table has been waiting a very long time, so let's start with him.
Amir Sapkara from University of Maryland. First of all, Kirk, I want to commend you first. It's a great leadership in undertaking this in terms of the household air pollution. Looking into the future, there are certain limitations of this report that came out that we recognize, and one of them is use of this exposure response function, one exposure response function for the entire world population that we know have a very different underlying susceptibility. So how can we account for that in the future? And just to give you an example, so if somebody has ALRI in India where the population, close to 60% of the population are malnourished, versus somebody in Czech Republic that still use solid fuels, but the prevalence of malnutrition is much lower. The prognosis is going to be very different. So these are, and we know this, right? So the question is, how can we take such things into account moving forward? And then this is an area I see tremendous potential for institutions like Alliance, where we can perhaps work towards collecting population or region-specific information and exposure response functions. So I was wondering if you could comment on that.
Well, thank you.
Just quickly, Kirk, we have 5 minutes, so if we, two more
quickly,
questions.
Lynn mentioned, referred to this too. I mean, in environmental science, you've all heard of the NIMBY Syndrome, not in my backyard. Everybody wants a garbage dump and nobody wants it next to them. Well, in environmental health, we run into the NIMBY Syndrome. Must be in my backyard. I don't care how many dead Guatemalan babies you find. We have to find some dead Indian babies, and maybe some dead Northern Indian babies and dead Southern Indian babies too. Everybody wants to repeat everything in their own local jurisdiction. And you can understand there are differences, some. Local evidence is more powerful. But you can't repeat every study in every village in the world. And in general, I sort of disagree. The WHO doesn't end up with different lead standards for Chinese kids or African kids. We don't end up, with major differences in the exposure-response relationships. When the evidence starts improving, they tend to coalesce. If you adjust for things that you know are important, like nutrition and so on. Now, sometimes they're not adjusted for these things, and you may be measuring, you've got confounding. But the question is, when have you got enough for policy? And, in the case of pneumonia, we have one randomized trial from Guatemala. There's another one going on in Africa and another one going on in Nepal. That's the three major parts of the world, assuming the other two get, similar results. I would say that's pretty strong evidence. But obviously, it's going to be different, in highland Nepal and, in maybe the depths of the Congo and whatever. But for policy, that's what I'm saying.
Great. We have 2 questions and 4 minutes left, so I'm going to take them together. The gentleman in the front and then the gentleman in the back.
John Balbus with the National Institute of Environmental Health Sciences. Really quickly, tying together some of the comments here about what's new about this report and new alliances that may be made from it. The cardiovascular disease is obviously a huge part of it, and we've alluded already to the global movement to combat non-communicable diseases and the fact that they are focusing on the 4 adult risk factors. So what are the options here for both influencing country policy on the NCDs and also perhaps getting with the NCD Alliance, the large international NGOs working on this, to try to get them to broaden their agenda?
Great. And then the gentleman in the back.
Yes, good afternoon. This is Samir Akbar from the World Bank. And thanks, Kirk, for a great presentation, and to all of you for shedding light on this issue. Kalpana, you've alluded a number of times to this issue of piggybacking on other programs. Just perhaps it's more cost effective, it makes more sense, instead of launching something that is cookstove focused. I mean, we all know that it's easier said than done. I mean, we all are sort of used to working in our sort of sectoral silos, so to say. So, trying to piggyback, and I think you're trying to do that with the maternal health sector program in Haryana and India. Realistically speaking, and I mean, I want you to really sort of take off the official hat and talk to us about how in India, if you wanted to do this and piggyback a program on cookstoves in the health sector or in the energy sector, short of talking about fuel switching, moving to electricity or LPG, how can one do this? I mean, it's makes a lot of sense, but it's very hard to do that on the ground. The second question I have is, and something that Kirk alluded to, is, I mean, when you gave this example of the cognitive effects study, and it was more newsworthy. So globally, what's more newsworthy now that would make this sort of get immediate traction in the policy arena on this issue? People talk a lot about nowadays about links to the climate mitigation agenda, linked to emissions of black carbon, for example, from cookstoves. I don't know if the jury is still out on that or not, and maybe you can shed some light on that. But does that provide an entry point to sort of raise the profile of this issue in terms of moving towards reducing emissions? not looking at it from the health effects perspective, but we're really moving up, which is where we need to go in terms of really facilitating the switch to cleaner fuels, or however, so reducing emissions.
Great.
Thanks.
Thank you. So we have two questions that actually come together quite nicely and are a good point to sum up on. So I'm going to ask you to do that as we work down the row here. We have one, which is how to integrate interventions on the local level into existing policies. We have the other, which is how to integrate them both on the global level, what to attach to that will get attention, but specifically NCDs. I want to add to that as maybe two of you can take the local side and two of you can take the global side. Of course, we are now moving to a rethinking of the Millennium Development Goals, maybe the Sustainable Development Goals. What does this report do for that? So I don't know if two of you want to volunteer to talk a little bit about how this might be integrated on the local level in programs, and then two of you on the other side. Do you want to try local?
Sure. Yeah, to answer John's question first on how it, I think there's some fantastic opportunities to the CVD burden. Without the CVD burden, I think it would, by the GBD assessment itself, it would have been a very difficult exercise from an exposure point of view and from a mechanistic toxicology point of view to be even, talking to the CVD community in India. And there are lots of, cohort studies that are going on concerning CVD. So there's an interesting opportunity to apply exposure models, exposure assessment to ongoing studies to generate this evidence very quickly, and even piggyback this as an additional intervention to ongoing dietary or other, randomized control trials that are in progress. The second question that Samir alluded to, clearly, I don't have a magic answer, as you know very well from the challenges of that region. But what I meant when I said piggyback was not to put the responsibility of clean cookstove technology to the health sector. What I meant was to add the health to ongoing efforts. So say for example, the urban air quality has a guideline already. Use the health evidence here to add this to the indoor air quality. The indoor air quality would still be the responsibility of the Ministry of the Environment. And if we are looking at piggybacking on from a disease point of view, if there are already ALRI folks that are, there is a pneumonia vaccine trial that is going on, or pneumonia immunizations that are going on, then to use this as a piggybacking opportunity. So my piggybacking that I was envisioning was more at an evidence-informing platform as opposed to a policy implementation platform. To facilitate the policy implementation by synergies in the evidence-informing process. Understand what that policymaker wants, and then inform them in that particular way.
Great. Kirk, a minute on how to integrate these into local or national efforts? This data is...
well, I think there are two that haven't really come out so far. One is the secondhand cook smoke issue. It has such an important influence on outdoor air pollution. Well, most countries, let's take the two biggest ones, that have serious concerns about outdoor air pollution are doing something. India just building 3,000 monitoring stations around the country, but not one in rural areas, because they haven't seen outdoor air pollution as a rural problem. But it is a serious rural problem, even aside from, well, not thinking about indoors, just plenty of air pollution outside of cities in India and China and elsewhere in the world, even Mexico and so on. So getting this this is a piggyback, if you like, or bringing in the household into the metric that's the rubric that's already been accepted in these big countries. Let's just take those three: Mexico, India, and China are trying to do something about their their outdoor air pollution, but they haven't taken into account the fact that they need to consider the rural population and the household contribution. That, I think, is probably cost-effective from an outdoor air pollution stance to get clean combustion in households. Forget what happens in the household. So that's one. The climate one, as you know, we started the work on the climate co-benefits in 1990, did the first measurements. And, well, the whole climate thing is kind of stalled now. And so hooking your star to that particular wagon, it doesn't, when it just start, stuck in the mud, and it doesn't look, for international efforts. But that may get out of the mud eventually, and maybe the world will do something about climate. Yeah, there is an interaction between household pollutants and the climate. It's not a simple one, and the science is tricky. But yes, I think it is a potential way of getting some resources here.
Great. Now to our other two panelists on the global side, how to integrate this into the NCD agenda or SDG.
Well, I'll start, and I think that the problem is that the kinds of health issues that we're confronting today, whether it's climate-related public health problems, chronic diseases, this problem of unhealthy indoor air, these are not simple problems that are amenable to single solutions. These are not problems that we can eradicate one at a time. We've kind of gone through those issues. And they require collaboration across many sectors, but they also require strengthening of health systems. I think that, if there's one thing that I think in the global agenda, it's very important, and it connects very much to what's going on in local communities, it's that need to strengthen health systems. And particularly at the community level, those health workers who do, basic care, but also do basic public health, and the training of those people. The paucity of trained public health individuals globally is an embarrassment. It's a huge embarrassment. And we have the capacity, I think, to do that training, but we haven't made use of that. And so that's the message I wanted to end with.
Great. And Sumi, you get the last word.
Yeah, and I think that it really is essential. I mean, it's always been a bit of a challenge, I think, because household air pollution cuts across so many different sectors, but we're often a major public health issue where the intervention is not lying directly within the clinical realm, which has been somewhat of a challenge. And I think that this is one area where this kind of comparative risk assessment effort really is very helpful for us, because we are actually at the Alliance a member of the NCD Alliance, have over the past year worked very hard to have strong relationships with American Cancer Society, with World Lung Foundation, World Heart Federation, but always under the guise of saying, look, here's our evidence, guys. We're also a very important risk factor. Now that this kind of comes up within more of this global comparative risk assessment, I think it'll be very much more on people's radar. So that's wonderful to have.
Great. That's a fantastic note to end on. Please join me in thanking our panel.